I'm Dr. Thakur, one of the consultant cardiologists and your TPD and local host for today. Of course, these are not normal times, so we're having to do this virtually, but we have a really good program laid out with a guest speaker, Dr. Manoj Makaria, who's a cardiologist from Royal Free Hospital, London. We'll be covering some really good scenarios in acute cardiology of interest to yourselves. And this will perhaps go on till about 3 o'clock with a very brief comfort break then. Timings are a little bit flexible. And then we'll have a arrhythmia update, again, case-based learning style by Sachin, who's a cardiology SDR with us, who would also be covering new medications for heart failure, which seems to be a contentious issue currently. My role throughout would be to moderate your questions, queries through the chat box. Please keep them coming, and I'll be trying to address them as much as I can so that it doesn't really interfere with the speakers and the time. So there'll be a break after the first session or the first talk. Feedback link you might have received by now, or you will receive soon, and then certificates will be issued accordingly. So without further ado, I'm going to be handing over to Manoj to get on with things. Manoj, if you're around, then please start off with your talk. Thank you.
Hello, good evening, good afternoon, everyone. I'm just sharing my screen. Just let me know when you see my screen. Can you see it?
Yes.
Yes, we can.
Yeah. Okay. I'm Dr. Manoj Makaria. I'm one of the specialty doctor in cardiology, working at Royal Free Hospital. Thanks, Dr. Thakur, for inviting me to speak to in this forum. I will be discussing some acute cardiology cases that we normally see when you do on call in A&E. Let me go to the. So what we were learning through the review of the cases, making some diagnosis and seeing how we will manage the cases that we see. It should be interactive, and Dr. Thakur will be moderating the question answer thing. We will discuss following scenario: chest pain, syncope, and heart failure. So chest pain, as you know, suspected ACS is the bulk of acute medicine take. It is one of the largest worldwide mortality cause. Up to 1/3 of acute medical take is chest pain. So we have to be dealing with chest pain every day. We need to decide whether this chest pain is ACS or not. And if it's ACS, then weigh the risk of bleeding and ischemia and prescribe therapy accordingly. Just to remind that patients with chest pain can have normal ECG and normal engines, and despite that, they can have coronary syndrome. So acute coronary syndrome is a broad spectrum of disease, starting with unstable angina to acute ST elevation MI. How do we differentiate between these? Is through the history, ECG, and imaging like echo, and through the blood markers, cardiac enzymes. So let's have a look at the case scenario. So a 67-year-old male come to A&E and give a history of crushing chest pain across the chest, going to left arm, feeling short of breath and nauseous. He doesn't have any previous cardiac history. What else we need to do, or what else need to ask him? So we just need to take a brief history from him. So is he any past medical history to rule out any risk, to have a risk factor profile? So he's diabetic, hypertensive, dyslipidemic. He's taking metformin, losartan, and he's on some inhaler. His father had MI at the age of 40 and had stenting. He's a smoker and smoked 2 packs of cigarettes for the last 20 years. He drinks a bottle of wine. We briefly examining him, we found that he's hypertensive. His ops are otherwise stable. He has few crepes in the chest. Otherwise, examination was unremarkable. What we will do the next? So the question is what we will do the next. So we'll look at the ECG because ECG will achieve the diagnosis, whether this patient has acute coronary syndrome or not. So this ECG is showing classical acute ST elevation infralateral MI. As you can see, the ST elevation in lead 2, 3 AVF and V5, V6 that would suggest with reciprocal changes in anterior chest lead V1, V2, V3. And this will indicate acute ST elevation in inferior wall MI. So what should we do next? So we quickly do the chest X-ray while we are waiting to thinking what to do next. His chest X-ray didn't show any remarkable changes except minor vascular marking in the upper lobes. His blood test was sent by the triage nurse, and his troponin has come back as more than 1,000. His BLP is also slightly elevated. His HbA1c is high, and his lipids are elevated. So what is the diagnosis? So diagnosis is acute ST elevation MI. So what should we manage? How should we manage these patients? So we will come to the management in a minute. Just let's look at another case. So he's a 56-year-old man who presenting with chest pain that usually occurring with exertion in last 1 week. He previously had stenting to his LAD and is normally on aspirin, statin, beta blocker, and ACE inhibitor. He was well up till a week ago, and his BP is well controlled. He comes to A&E, the examination is unremarkable, and his bloods are awaited, but he had an ECG. And this is his ECG. As you can see, it shows a sinus rhythm, but there are some ST depression in lateral leads, notably one AVL V3 to V6. On the basis of this history and the ECG changes, we can make a diagnosis that this patient has got acute coronary syndrome. So coming to the management of acute coronary syndrome, whether it's ST elevation MI or non-ST elevation MI, when it comes to A&E, the common management would be pain relief with morphine. Make sure that you give some antiemetic in the form of metoclopramide. Oxygen is required if the oxygen saturation is less than 93 to 94%. Usually this chest pain responds well to nitrate, so GT and spray should be given unless patient is hypotensive. The aspirin, we should be giving 300 milligram either chewed or dissolved. Depending upon the local protocol, these patients are loaded with either ticagrelor 180 milligram, clopidogrel 300 to 600 milligram, depending upon the hospital protocol, and some institute use prasugrel 60 milligram loading as well. If the patient does not have ST elevation MI, then patient should be given low molecular weight heparin in the form of fondaparinux. You should not be using fondaparinux if the creatinine is high, especially if it is more than 265. In that scenario, use unfractionated heparin. For ST elevation MI, time is the muscle. So we have to thinking about while you are after looking the ECG, you need to activate the acute primary PCI pathway. Because if the PCI is done within 2 hours or 120 minutes, what we call to balloon time, then the results are excellent. If the PCI is delayed, then we have to consider thrombolysis. Normally nowadays, PCI is done through the radial access, and most of the time we use drug-eluting stent. All these patients would have been loaded with an antiplatelet, either prasugrel, ticagrelor, or clopidogrel. If thrombolysis is failed, then if PCI is not available, then thrombolysis can be a choice. But nowadays, most of the area is covered by primary PCI centers, and hopefully we would be able to provide PCI. If the patient doesn't have ST elevation MI, then normally we manage them with beta blocker, nitrate, high dose statin, ACE inhibitor. All these non-ST elevation MI should be considered for urgent coronary angiography within 72 hours. And all these patients should have an echo. How do we decide which patients should have an angiography early? So for that, we have got a scoring system. There are two scoring systems which has been used, GRACE scoring system or TIMI risk score. Nowadays, we use GRACE scoring system. that predicts 6-month mortality in these patients. And it uses age, heart rate, blood pressure, CLIP class of heart failure, whether patient has a cardiac arrest or not, whether the cardiac markers are elevated, and ECG changes. If the score, if the 6 months mortality is less than 3%, it is called low risk. If it is more than 6%, then it's high risk. All high risk patients should have a coronary angiogram and PCI within 72 hours. So after having the PCI, all these patients should have further long-term management plan, what we call secondary prevention. These patients should be on aspirin for rest of their life. Normally, a second antiplatelet is given for at least a year. Depending upon the intervention, some intervention cardiologists recommend 18 months, 24 months, or 36 months of dual antiplatelet therapy. Most of these patients should be on beta blocker, and it should be reviewed after a year of beta blocker. ACE inhibitor statin should be for rest of the life. Important thing we should look at is the modification of risk factors, especially diabetes and high cholesterol. We should be aiming for total cholesterol less than 140 and LDL of less than 70. And the dose of statin should be titrated. Patients should be advised about lifestyle changes, especially in terms of quitting smoking, the regular exercise. For that, cardiac rehabilitation is very important, and all these patients should be referred for cardiac rehabilitation. Nowadays, we don't see much of complication of acute MI, but you can come across sometimes if the MI is presented, if the patient is presenting delayed. So complication can be classified as early complication that happens within 72 hours, or late complication that happens after 72 hours. Early complication could be death, cardiogenic shock, pulmonary edema, ventricular arrhythmia, myocardial rupture, or thromboembolism. And the late complication usually are ventricular wall rupture, valvular regurgitation, especially mitral regurgitation, ventricular aneurysm, especially in the patients with LAD infarct, cardiac tamponade. Dressler syndrome is very common if the patient is not hasn't had any intervention done, and thromboembolism again because of the LV apex clot. This patient can present atypically. Not all patients present with chest pain. They can present atypically, especially if they are diabetic, elderly, or females. The presentation could be just simple nausea, vomiting, dizziness, profuse sweating, burping, indigestion. Sometimes this patient can present with palpitation or new onset AF. And pain, instead of chest, it could be just in jaw, neck, or arm. So there should be high index of suspicion when we are dealing with this patient, especially in diabetic or elderly. All chest pains are treated as acute coronary syndrome, but there should be a broad differential diagnosis, and we should be keeping this in mind. The cardiac chest pain could be because of acute coronary syndrome, or could be chronic stable angina. It can also be because of pericarditis and aortic dissection. But sometimes respiratory diseases like pulmonary embolism, pneumothorax, or pneumonia can present with the chest pain, but they are slightly different characteristic. Esophageal spasm, gastroesophageal reflux disease can also present as a retrosternal discomfort mimicking cardiac symptom. Costochondritis and trauma are some other chest pain, but these are typically persistent, tender to touch, and are easy to differentiate. Let's come to a couple of differential diagnoses that's very important. Aortic dissection is very important because of a couple of other reasons. What is aortic dissection? Sometimes intima of the aorta get a tear, and the blood start collecting between intima and media, causing occlusion of the lumen. Especially if it's around the aortic root, it can compress the coronary arteries and can present as acute coronary syndrome. These patients usually present with sudden severe chest pain. Sometimes it radiates to the back, and patients are usually anxious, sweaty, and nauseous. Aortic dissection can be type A or type B. Type A usually involves the ascending aorta and root, and it can mimic as acute coronary syndrome. In this patients, if you give a loading dose of antiplatelet or low molecular heparin, it could be catastrophic. So we have to be a bit careful when we are dealing or suspecting any patient where we are thinking it could be aortic dissection. We must, if we are suspecting aortic dissection, then we must check for the pulses in all the limbs. We should do the chest X-ray to look for any mediastinum widening or aortic widening. Echo is a quick echo, bedside echo can give us a hint of aortic dissection. As you can see, sometimes the aortic flap, or sometimes there is a pericardial effusion that will suggest that patient may have aortic dissection. CT aortogram is a gold standard. Normally, type A aortic dissection is a medical emergency and should be treated with surgery. The type B is normally dissection in a descending aorta, and it can be managed medically. Pericarditis is another syndrome where patient can present as a chest pain. Normally, these chest pains are pleuritic chest pain. Pleuritic means pain that is worse with the posture, breathing in and out. If you are lucky, you can hear a friction rub that is best heard in left parasternal area at the end of inspiration or after full expiration, and is best when patient is leaning forward. ECG findings are interesting. You can have a global ST segment elevation, often associated with ST depression, the PR segment depression. Chest X-ray could be useful to differentiate other causes of chest pain like pneumothorax and pneumonia. Lab results are not very helpful except if there is inflammatory, then the CRP may be raised. Transthoracic echo could be useful if the chest pain patients are hemodynamically unstable to rule out any large pericardial collection and cardiac tamponade. This is a classical ECG of pericarditis where you can see some global ST elevation with a concavity upward and with some PR segment depression that would indicate that this patient has possible pericarditis. The other important differential diagnosis of chest pain should be pulmonary embolism. Again, these patients present with breathlessness with pleuritic chest pain. Most of the time, they have some risk factor for venous thromboembolism, either immobility, recent surgery, recent long-haul flight, but sometimes there could be unprovoked pulmonary embolism. Hemoptysis is not very common in these patients, and CT pulmonary angiogram is a gold standard for the diagnosis of pulmonary embolism. D-dimer is only useful if suspicion is low, and normally these patients are managed with low molecular heparin followed by a long-term anticoagulation depending upon the underlying risk factors, either 3 months, 6 months, or long-term. It all depends what the clinical scenario is. Sometimes this patient may have a hemodynamically compromised with hypotension, tachycardia, hypoxia, with raised troponin and BNP level, which means we may have to consider thrombolysis. So to conclude the chest pain, all chest pain patients should be considered as an ACS until proven otherwise with ECG and blood test and should be managed accordingly. I would move forward to another common presentation that we see in A&E. Patient comes with short-term or long-term breathlessness, and we think the patient may have a heart failure depending upon the symptom of. So what is the heart failure? Or congestive cardiac failure? It's an imbalance in pump function in which heart fails to maintain the circulation of blood adequately. It only mostly happens when ventricles are deranged, either they are enlarged and ineffective in pump, or they are stiff so that they can't pump adequately. What it leads building of the fluid in the lungs and the periphery, and we call it as a pump failure. The symptom of heart failure is normally fatigue, shortness of breath. Patient may give history of orthopnea and PND. If there is a peripheral edema, then you will have leg swelling and abdominal distension. If the patient is bedbound, then they may have a sacral edema. So it's important to look at the sacrum of the patient who are bedbound. Sometimes they can present with cough with pink frothy sputum that will indicate acute pulmonary edema. That would be again medical emergency. Patient can have chest pain and palpitation, which may decompensate this patient who has chronic heart failure. If you're looking for signs, normally these patients are tachycardic, they could be hypertensive and tachypneic. JVP is normally elevated. It's very important when you're looking for JVP that they are lying at 45 degrees in the bed, and you should be looking at tangentially to look the pulsation in the neck. Patient chest examination may reveal fine cracks in the lungs. A cardiovascular examination will normally say either S3, S4 gallop, depending upon the underlying cause. You may have here the murmur if the patient has significant underlying valvular heart disease. Patient may have significant ankle edema or abdominal distension because of ascites as well. So heart failure could be from various etiology. It could be because of chronic coronary artery disease, and that patients will present as chronic heart failure. Hypertensive heart failure could be either acute or chronic. Valvular heart disease normally gradually worsen, and these patients normally present as a chronic heart failure. Infection can precipitate the heart failure in patients who have got chronic congestive cardiac failure. Dysrhythmia, especially atrial fibrillation, is notoriously decompensate patients with congestive cardiac failure. Acute alcohol intake can present as acute heart failure, especially if they precipitate atrial fibrillation. Acute MI patient will present as acute heart failure in pulmonary edema. In diabetes, normally patients have a chronic coronary artery disease or diabetic cardiomyopathy presenting as a chronic heart failure. All these patients should have full blood count, urea electrolyte, LFT, and thyroid function test. Troponin and BNP is important in these patients to rule out underlying coronary artery disease. BNP is important differentiating blood test that will differentiate cardiac cause of breathlessness from non-cardiac cause of breathlessness. HbA1c lipids and RNA study are also important in workup for these patients with heart failure. ECG, chest X-ray are important investigation in A&E. Once we have stabilized the patient, then patients should be considered for echocardiogram, and subsequently, depending upon the etiology, they would need a coronary angiogram or cardiac MRI. So let's look at the case scenario. You have 72-year-old female who's coming to ED with worsening shortness of breath and orthopnea for 2 months, and it acutely precipitated breathlessness after having a Chinese food. Her examination was unremarkable, except that she has got elevated JVP, few crackles in the lung, and her leg edema. Her blood ECG and chest X-ray are awaited. What do you think, what's the diagnosis is here, and how confident you are that this patient has acute heart failure? I would say I'm in the middle, 41 to 60% chance that this patient had a heart failure on the basis of the clinical presentation. So I will wait for ECG X-ray to come back, and her X-ray shows that she has got bilateral pleural effusion and evidence of pulmonary congestion as well. When we look at the ECG, her ECG shows sinus rhythm with the left bundle branch block. With all these findings added to the clinical presentation, I would say patient have a high likelihood that patient is a diagnosis of acute heart failure. When we look at the blood test, her anti-proBNP is significantly raised. Her creatinine is raised slightly. Her trops were negative. So our diagnosis here would be acute decompensated congestive cardiac failure. We got an echo done for her, and it shows that her LV is dilated. And although these are not moving images, so I can't really show how the functions are working. And in the 4-chamber view, we can also see that apex appears to be dilated and aneurysmal. So after making the diagnosis of heart failure in this patient should be managed acutely in A&E. Normally, this mainstay of therapy in this patient would be intravenous loop diuretics in the form of furosemide. You can give either boluses 3 times a day or infusion, depending upon your local protocol. This is to relieve the congestion. We need to make sure that blood pressure is adequately controlled. If the patient has good blood pressure, then vasodilator like GTN infusion can be used. But if the patient is hypotensive, then patient may need some an inotrope support. Patient would need continuous monitoring, continuous assessment of the urine output and intake, and depending upon the etiology, all these patients will need further management. So the management of heart failure after stabilizing from IV diuretics will involve adding ACE inhibitor or ARB if they are intolerant to ACE inhibitor. Beta blocker is also important in these patients. After titrating the dose of ACE inhibitor and beta blocker, we reassess their symptoms. If they remain symptomatic, means class 2 to 4, then we should add a mineralocorticoid receptor antagonist like epinephrine or spironolactone. If they are stable, then we monitor them on a regular basis. The further management of heart failure will depend upon how their LV function is and what is the etiology of their heart failure. The important practical tips that all this patient comes to A&E because something has precipitated their heart failure, whether it's an infection, whether there's a dysarrhythmia, whether they are failed to, they're non-compliant with the medication. We should aim to get the ECG and chest X-ray quickly to assess what is the cause for a precipitating factor. NT-proBNP and troponins are important, and echocardiogram normally helps in differentiating patient with preserved LV systolic function and reduced LV systolic function, because the long-term management is slightly different in these patients. So I think we are doing fine from the time point of view. So we will discuss some further cases which present with the syncope. So syncope is defined as a transient loss of consciousness due to cerebral hypoperfusion. It is usually rapid onset, short duration, and mostly recovered spontaneously. Most of the syncope can be defined as in the 3 broad group. One is big group is cardiac syncope. The other one is reflex syncope, and the third one is syncope because of related to orthostatic hypotension. We are more worried about cardiac syncope because that could be life-threatening. Most of the time, the vasovagal syncope because of inappropriate reflex and orthostatic hypotension, which usually happens because of inadequate venous return or benign and self-limiting. So how do we evaluate syncope? We have to first answer the question, is this loss of consciousness is really syncope, or is it because of non-syncopal loss of consciousness like seizure? We need to establish a clear-cut etiological diagnosis, and then we look for high-risk cardiovascular factors that can cause future cardiovascular event or death. So initial evaluation of syncope involves good history. History taking is very important in this patient because most of the time history will give us some clue whether it's a reflex syncope or whether it's a cardiac syncope. Examination is most of the time is unremarkable, except if the patient has got underlying valvular heart disease, in which case patient may have underlying severe aortic stenosis and can present as a syncope. Lying and standing blood pressure is very important, especially blood pressure should be, standing blood pressure should be taken after 3 minutes of standing. And if there's a significant drop in blood pressure, then we can establish a diagnosis of orthostatic hypotension. ECG is a cornerstone of the diagnosis of syncope. 12-lead ECG to start with, and then we can move on to prolonged monitoring if required. So, quick workup of transient loss of consciousness. If there is no transient loss of consciousness, if there is no syncope, then we need to look at the different causes. If the patient has syncope, then we need to examine them, do the ECG, check the lying and standing blood pressure, and if there is a high likelihood diagnosis, then start treatment. If there is still uncertainty whether this is a syncope or not, then we have to risk stratify them, and accordingly, whether we need to think about either admitting the patient for further evaluation on doing some low, if they are low risk, then consider doing outpatient investigation. So discussing some cases, so look at this case. A 70-year-old male is a shop owner, is diabetic and very independent. He's coming with sudden onset shortness of breath that started a week ago, and he's progressively more breathless and syncope. And he comes to A&E because his wife forces him to go to A&E because he's dizzy. When he comes to A&E, his heart rate is 35, and his blood pressure is 158/60. His bloods were almost normal. His troponin levels were not significantly elevated. And his ECG shows this. So if you look at the ECG closely, it's a quite bradycardic. And if I put my cursor there, you can see there is a 2 P wave and 1 QRS complex. So this patient possibly probably has got high degree AV block, type 2 second degree AV block, Movish type 2 second degree AV block. So this patient, so question is, what should we do next? Should we insert a temporary wire? Should we start an isoprene infusion and monitor till we do a permanent pacemaker implantation? Should we admit him in CCU for urgent same-day pacemaker implantation, or should we discharge him with urgent cardiology follow-up? I think the option C is out of question. We should not do that because patient is bradycardic and symptomatic. So what we do? So patient has high risk ECG. So patient was started on isoprene infusion while waiting for permanent pacemaker implantation. And patient had a permanent pacemaker implantation next day, and patient went home without any significant problem. So now coming to second case, so 84-year-old gentleman who used to have syncopal episode in young. He had previous MI and had a PCI to right conveyor and left circumflex arteries. He keep on having syncopal episodes, and people thought it's a vasovagal. He has multiple halters that didn't show anything. He again came to A&E with recurrent syncopal episode in last 3 weeks. He has ejection systolic murmur, and his lying and standing blood pressure did not show any significant drop to suggest that it could be orthostatic hypotension. In view of ejection systolic murmur, he had echocardiogram that ruled out any significant aortic stenosis. His ECG is here that shows a normal sinus rhythm. There is PR interval is normal, QRS axis is normal, QRS complexes are narrow. So there is no evidence that patient has any evidence of conduction disease. So what should we do next? Should we discharge him with outpatient Holter? Should we implant a implantable loop recorder? Or should we send him directly for pacemaker implantation? So As I said, this patient already had multiple Holters and that haven't shown anything to suggest that what is the cause of his syncope. There is no enough evidence to give him a permanent pacemaker implantation because we haven't documented any bradyarrhythmia to correlate his syncope. So nowadays we are using implantable loop recorder very often. So it is a small device that is inserted under local anesthesia. It's a very simple half-an-hour procedure. Patient go to the lab and with small cut, it's five millimeter small cut, and we insert a small device that stays with the patient for 3 years, and it monitors the heart rate all the time, ECG all the time for 3 years. This patient had an episode and we interrogated his ECG and we found that patient had long asystole for almost more than 5 seconds. And this patient, and that's how we established the diagnosis that this patient has cardiac syncope because of sinus node disease. This patient had a pacemaker done and is doing well now. Looking at another case, is a 77-year-old man who is known to have type 2 diabetic hypertension, has got CKD stage 3. He is coming with history of collapse following sudden onset dizziness while he went to drop a grandkid off to the school. In A&E, he has a significant drop in his blood pressure that could be because of his antihypertensive. His investigations are because of CKD, he's got creatinine is elevated and he has got normocytic anemia with HB of 92. His ECG was done that shows on arrival, it shows atrial fibrillation with controlled ventricular rate. While he's in A&E, he's had another ECG that shows that his ECG has reverted to sinus rhythm. So probably this patient has got paroxysmal atrial fibrillation. But while before being discharged from the hospital, the plan was to send him home with the Holter and event recorder to see if he can establish any diagnosis of his symptom. But before he goes home, he developed some symptom and he had another ECG done. And this time his ECG shows that he has got significant ST depression in infralateral leads. So he was sent for an angiogram that shows that he has got significant right coronary artery disease and significant left coronary artery disease, which were stented. And after stenting, he hasn't had any further rhythm abnormality and he hasn't had any syncope. And he was discharged home with the Holter monitor to rule out any possible further arrhythmia. So the bottom line here is that this patient's symptoms were possibly related to transient arrhythmias because of chronic coronary artery disease. Moving on to another case, this is a 40-year-old gentleman who is morbidly obese, otherwise he is well. He's coming with history of palpitation and near syncope or pre-syncope. When he comes to A&E, he's stable but tachycardic, and he has an ECG done. And as you can see, his ECG shows tachycardia is quite near QRS. It looks very regular. There is no definitive P wave noted in there, but if you look at closely in V1, the slight indentation in the upper stroke of the T wave, and that would probably say is a retrograde P wave conduction. So what is the diagnosis? I'm pretty sure most of you have thought, oh, this is the narrow carriage tachycardia, SVT. So how do we manage this? So this patient was given vagal maneuver that didn't work. So he had adenosine. His blood showed nothing significant. His troughs were non-dynamic, mildly raised. His thyroid function was normal. His electrolytes were normal, and his bedside echo was normal. After adenosine, his ECG shows this. So what is the diagnosis? What do you think this is the diagnosis? Here is the diagnosis. I will give a brief pause to see if anybody of you will type some diagnosis. So what we see here is the patient is in sinus rhythm, but has a very short PR interval. And if you look at the chest lead and all the leads, there is a slurred upstroke of airway. So this is a case where patient has got accessory pathway, or what we call Wolff-Parkinson syndrome or WPW syndrome. So the presentation of his SVT was because of accessory pathway conduction causing tachycardia. This patient should be managed with the radiofrequency ablation, which is a curative treatment. I will stop sharing my presentation here.
Right, thank you, Manoj. I think we have about 10 minutes of time roughly. So anyone wants to ask a question, feel free to speak out. I don't think we have more than 35 attendees, so we can have a discussion if you like, please. I've just kind of typed that WPW pattern is manifest on the ECG, but don't be surprised if you see someone with a Wolff-Parkinson white pattern manifest today and maybe not tomorrow. It can come and go, or maybe present all the time. So, and that's what I was typing when Manoj stopped. So please ask questions if any clarities. I'll just go through. So your first scenario was ST elevation. Was it ACS? Yeah, and I think the take home from that, Manoj, I think you mentioned that it's chest pain of any kind, especially if it's cardiac sounding, consider ACS unless and until proved otherwise.
Yeah.
With your prior approval, I typed in triple rule out as a standard practice in many places now with a contrast CT straight away, which effectively rules out PE, a dissection, and also
significant coronary
radiographic abnormalities. And it is established, at least in your hospital, I guess, in Royal Free, you have triple rule out as a standard test. Now, there's a question coming in just now. In the workup for heart failure iron studies, is this to look for hemochromatosis or something else?
So this is the heart failure. This is one of the precipitating cause, because most of these patients are very symptomatic with tiredness and lethargy. And the studies have shown that these patients lacking iron store, and replacing iron improve their symptom.
Yeah.
And hemochromatosis could be one of the cause for heart failure. Normally, this happens with heart failure with preserved systolic function.
So just to top up on that, that question's being asked by Vinesh. So Vinesh, what's the kind of thing is, there's plenty of evidence that correcting iron deficiency anemia has significant impact on heart failure management. And so that's one common thing we would look at straight away in terms of FBCs. And if there's any indication of iron deficiency, you'd like to know a bit more. Currently, we have dedicated units, the transfusion units or infusion units in the hospitals around the country are providing routine iron infusions to many of the patients with heart failure, and it's happening in Pinderfields Hospital locally here as well. So people who need that iron infusion layers through hematology, they come and have it done. It has really gratifying effects on treatment along with whatever else you're doing for them. Hemochromatosis, of course, will cause infiltrative disease because of iron excess. So that'll affect the muscle in a different way than iron deficiency, which would effectively be a lack of oxygen carrying capacity, which needs to be corrected along with everything else. Thank you. Any other question at all? You can type if you like. So a good few people thought the ECG was WPW. That's really good. So just bear in mind that in general, if Manoj would agree, that these SVTs are generally much faster, and they can be with hemodynamic compromise rather than the usual SVT you might come across in terms of not being that unwell, but just having palpitation. But the pre-excited WPW SVTs behave slightly differently in terms of faster rates, more hemodynamic compromise, and there's a potential that if their antegrade pathway of the SVT is going through the accessory pathway, then they're conducting very fast, and there is a potential that they might go into atrial fibrillation. If they have AF at the top, then they have effectively VF in the ventricle because of the accessory pathway conduction, and that is an emergency. Patient needs to generally, we see 1 or 2 cases every year, and they go straight to cardiac EP lab, generally straight blue lighted, and then to go emergency ablation. So just as a top up on that. Right, so if there are no further questions, then what we'll do, perhaps we will take a quick break. It's 14:50 now. We'll come back at 3 p.m. Make sure you still would need to stay logged in for attendance purposes, and then we'll start with our second bit of the session. If that's okay, then just type yes, and then we can take a break. Thanks.